and welcome. I think it's been almost 2 weeks since we last uh, spoke. So today, what I'm going to do is, for a change, rather than reviewing a journal, I'll take and do a case presentation. And this is one of my cases. And I think it'd be good to have some case presentations being done, because I think what that will give is, that'll give a slightly better idea and understanding into much of the basics that we teach. So let's look at this patient, and she's a 34-year-old lady who's trying for a pregnancy for 2 years, had regular cycles, her tubes were open, she had fibroids, the sperm was normal, and she had 3 IUI cycles which were stimulated, and these were unsuccessful. So she said, well, I want to try IVF. So she came to see me, and having been told that she didn't stand a chance in IVF. So when we had a look at her in October 2019, her day 2, day 3 bloods were done. Her FSH was high, it was 14.6, the LH was 4.4, and the AMH was 3 pmolar liter. And I think in your in India, and where you do nanogram, it's probably 0.3 to make it easy. So and then they were going away. So I said, when you come back, let's have a look at your day 2 hormones again, and let's look at your FSH, which was 9.8, the LH 4.9, and the AMH came back as 2.8 pmolar liter. So, here we come across a situation where you look at age and you say the woman is young, and then you look at her AMH. And those of us who believe that AMH is the prime indicator of ovarian response need to have a general rethink, because I think you have to look at certain different parameters. So, and these were my scans. So on the iPad, you can cut and paste and you can take it out. And the first scan, and she had got 2 fibroids, and she was very keen not to have those fibroids removed. And the endometrium was absolutely fine. The right ovary showed about 5 antral follicles, and the left ovary showed about 6 antral follicles. And this was a follicular phase scan. So eventually, when she came back, I did a luteal phase scan on day 24. And it's very important when you scan, and I'll explain better to you when we go ahead with the discussion. So on day 24, I saw this fibroid was still there. So there was 8 antral follicles on the right side, and there were only 2 antral follicles on the left side, and there was a corpus luteum. So I said, well, come back when your period starts. And again, what I did not do is I did not get her for a scan at day 1, day 2, because in 6 days, the antral follicle counts are unlikely to change. So we said, well, why don't we scan her on day 8? So on day 8, what happens is, here, something different starts happening. And that's because the pituitary has already started increasing its FSH, and steadily the FSH goes up. And by that time, I've seen 8 antral follicles, and I've seen a total of 14 antral follicles, and that's within a period of around 14 days. So a gap of almost 13 to 14 days was there. So during this time, you saw a larger number of follicles, and I'll always label my follicles on the size. So 4 to 5 millimeter. And I'm more interested in follicles that are 4 to 5 millimeter and not less than 3 millimeter. And that's because follicles which are less than 4 millimeter tend to have a higher inhibitory aspect of AMH. So they are under control of the AMH. And follicles, as they become bigger, tend to be under less control of the AMH. And that is how you start understanding AMH better. So what does these 3 scans teach me? They taught me that 1, her FSH is variable, and her antral follicle count is variable. The AMH is low. So there's a window in which this lady can be able to start producing more follicles or recruiting follicles. So what is the difference between recruitment in the follicular phase and luteal phase? The follicular phase recruitment always sees a higher FSH. So to understand this, what you realize is that in the follicular phase, your FSH window is shorter, but the FSH secretion is higher. In the luteal phase, and which is in fact said to be the luteofollicular phase, does not have such a high FSH stimulation or innate FSH, but has a longer window and a wider window. So the two phases differ depending on how the window is, the FSH window is. And if you can basically look at follicles, and this is mainly for poor responders. For normal responders, I don't think it makes a large difference. But for poor responders, I think it makes a significant difference depending where the follicles are being recruited. So I said, let's start. And so what am I using? And in this case, there's a logic of me using clomiphene. And the logic of using clomiphene is that clomiphene causes sustained FSH rise. And also it causes sustained LH rise. So in effect, I'm using natural type of HMG where you're giving FSH and LH. And I gave a small dose of recombinant FSH. I think in poor responders, some evidence suggests that recombinant FSH may recruit more follicles. And again, that's because of the way the chemical is. So, and this is again, day 8, day 9 of stimulation. So have a look at what happens on day 6. So by that time, this is day 14 of stimulation, and there's already a dominant follicle. And I've got this unique way of looking at this folliculogram and being partially blind, which means I forget that this follicle is there. And remember one thing, that spontaneous LH rise does not affect smaller follicles. So if this follicle were to ovulate, that does not affect small follicles at all. So, and here, once you decide you have stimulation done, you can then increase the amount of gonadotrophins you give. And the logic behind that is that you don't see a huge disparity or asynchronous growth. And that is what you have seen. This cohort has been reasonably similar. And once they have escaped the inhibitory part of AMH, it is easier to give a more aggressive stimulation. So why did I start low? And I started low because I generally believe that it's sometimes these follicles, which are slightly larger, may recruit much better. And then I gave a combination, and I sometimes do that. Again, there is no scientific logic behind it. And the thing which I always warn my patients is that I don't know how your ovary is acting. And this is something which I always tell them. I'll tell them, I just don't know how your ovary is acting. Is it reflecting your low AMH, which means that you will see a poorer recruitment of oocytes. So the FOAT will be poorer, and the FOI, which we discussed earlier, both will be poorer. Or are you going to reflect your age, which means that you'll get good mature eggs and you'll get good blastocyst. So by the time she got to day 12 of stimulation, which is literally day 20 of the cycle, her estrogen was 18,323, phenomenal rise. And again, remember, this woman stands the risk of ovarian hyperstimulation syndrome. So I gave her an analog trigger and triggered ovulation. So when we looked at oocyte retrieval, so there were about 15 follicles, and we saw I got 10 oocytes, 9 of them were mature, and ICSI was done, 8 fertilized, 7 blastocysts were formed, ranging in 4 AA and 3 BB. They were sent for PGTA because that's what she desired, and 4 have come back being euploid. So let's go back and say, what do we tell this lady? We say, what have you behaved as, and how have you reflected your performance? And you reflected your performance exactly about what age should do. And at the age of 34 to 35, you generally tend to see about 40% aneuploidy. And as you grow older, the aneuploidy rate is higher. And so for aneuploidy, they're frozen, and she's awaiting a frozen embryo replacement cycle. And then you would say, oh, that's impossible. No, it's not, because, and this is one thing which I've always said with women with low AMH, and I'll explain my logic towards this. So what do we know now? We know that follicular recruitment is a constant phenomenon, and it's a wave or a continuous. So either follicles will get recruited in different waves, or it will be a continuous recruitment. It is not a follicular phase only. And the peak of the antral follicle count varies in cycle to cycle. Now, in poor responders, the pool of recruited follicle count will also vary. So what is important? It's important to know when to stimulate. So that is, the key word I've come across, and said, it's not just with what you stimulate, it's when you stimulate in a poor responder that counts. So once that was done, so when I say there are 3 waves, and what does it mean? That there are some women, almost every woman will recruit follicles into 2 waves. And there'll be a follicular phase recruitment and a luteal phase recruitment. Some women who have longer cycles will recruit 3 times. And again, you will see this recruitment happening even in the luteal phase. But there's only one ovulatory cycle. As humans, we'll have only one ovulatory cycles, but we'll see multiphasic recruitment. And if you can see what's happening, you'll be able to understand and see whether this woman recruits at what time at the best. So for this, I'll tell you a story, and I tell a story to a lot of people, and I say, what happens to an athlete? An athlete, as the athlete gets older, the athlete's reserves tend to do worse. So, and the athlete runs the track at a variable rate, and that's exactly what a poor responder does with a low AMH. A young poor responders have low reserves. So that young poor responder will recruit almost always very differently. And if you have a poor responder that recruits in a variable manner, the success rates are significantly better. So again, remember one thing, and I'll keep telling you, the luteal phase recruitment window is wider than the follicular phase recruitment window. And again, that the reason is important. So what was this case? This was a random follicular phase start. And that is something which is very important to realize. So you can either go for a random follicular phase start, which is very different from a random luteal phase start. And a random luteal phase start relies on a wider FSH window over which you can recruit more follicles. So now if you had, let's go back to that case, to the second scan. And when I scanned it on day 24, if I'd seen 14 follicles, my chances of recruiting follicles would have been far better than in the follicular phase. But this time, what I was relying on a random phase start based on a follicular phase. So what I relied on the pituitary FSH to start recruitment of follicles, and my stimulation ran piggyback over it, which basically meant that we let the pituitary do some part of the work while I decided to then supplement the FSH later on. Again, we'll say, think stimulation. So the question is how do we get more oocytes? Now, there's more and more data coming up that if the more the oocytes you get, the chances of pregnancy are better. So let's look at this study, and this is a brilliant study, and it came in one of the Italian papers called Pan Minerva Medica, and it's a very recent one. And when it says there's an age-related decline. So at the age of 35, how many blastocysts do you need for one euploid embryo? And with that as a 90% probability, and that's 4. Get to 45, and you need 29 blastocysts to be able to get to one euploid embryo. So have a look at it. And if you see, what is the most important factor that determines success? And that is age, and age alone seems to determine success. So your first job should be get more eggs, get more blastocysts, and then go have a look at and see how the aneuploidy will pan out. And it will be, again, age dependent. So if you got somebody who's 41 and produces 6 blastocysts, and you say, well, the chance of getting a euploid are still quite low. So, and this is a very simplistic way on IVF data. So number of oocytes needed. So let's forget about this. So to get one euploid embryo under the age of 35, you need 8 oocytes. Between 35 and 39, you need 11. Between 40 and 42, you'll need 17 oocytes to get euploid embryo. So again, these are more of statistical analysis, but what it is telling us is that age tends to have the most importance impact on oocyte numbers. So think a bit differently and think of a poor responders and try to find out. And I know many of you all who have come for the course which we conduct. And what do we say there? And I'll always say that classify things, make it simple, and simplify medicine. And in those cases, I think we'll answer questions a bit later because I think I find it difficult to talk and answer questions. So if you look at the types of poor responders, there's a young poor responders who has a good AFC variability, and there'll be a fixed AFC variability. And there's be a good old poor responder who has a good follicle variability or a fixed variability. And so find out what type of recruitment occurs for this lady. If she has a recruitment that is variable, then it gives you a better chance of recruiting more follicles and getting more eggs possibly. But if somebody has a fixed antral follicle count, I think there you have to be very frank and say, well, I don't think we can change the outcome to a large extent, which means either you have to undergo multiple cycles of stimulation, or you may have to tell her that possibly in 3 or 4 cycles, you may not get many eggs. So make it simple and do this classification. And then you have the options of treatment for a poor responder. And each of them is almost a huge, and when you came for the course and what we went through all the protocols with how you stimulate these cases. So you can either do a dual stimulation. It seems absolutely stunning, but it's quite challenging and quite challenging to a patient as well as to us. You can do a luteal phase stimulation, or you can do a random stimulation. And that is exactly what we mean by chasing the antral follicle. So how does luteal phase stimulation work? So you start the stimulation around a peak of antral follicle count. And again, I'll say the luteal phase window is wider. Now, there's good evidence from cancer patients to suggest that you can stimulate any time of a cycle. And in fact, there are studies after studies which suggest that whenever you stimulate, let it be the follicular phase stimulation or the luteal phase stimulation, egg quality, embryo quality, and euploid status is exactly the same. So when you come to dual stimulation, what is the principle? The principle is that you stimulate in both the follicular phase and the luteal phase. So to make this work, there is one prerequisite. For the first oocyte retrieval, you cannot give HCG as a trigger. Why? Because HCG luteinizes all follicles. LH starts the luteinizing process of only large follicles. So in dual stimulation, it teaches us that follicles are constantly recruited. In poor responders, some follicles may be of better quality. Do not drain all the small follicles at egg collection, and always use an analog trigger. And our experience has been quite extensive and mainly used in cancer patients. So this is how the person who came up with the luteal phase start decided to stimulate. And what he did in his paper was he started clomiphene, letrozole, and HMG 150 somewhere in between. And he gave MPA and he gave ibuprofen, and again, that is to prevent LH surge. Did a first oocyte retrieval with a generalized trigger, and then decided to start stimulating again and collected eggs again. So what is the prerequisite here? One is that there should be small follicles when you do the first egg collection. Now, it doesn't make sense if you have only 3 or 4 follicles of around 10 millimeter at oocyte retrieval, and you decide, let me go for another stimulation, because you can do that in the next cycle completely. Remember, the dual stimulation takes a huge toll on the woman, including physically, psychologically, and financially. So that is something which you'll have to think about is, are these cases? And often you'll get this idea on the day of egg collection. So, which means that you should be willing to use the analog trigger more than using the HCG trigger. And at oocyte retrieval, you can decide, well, I can see 6 small follicles, and this lady may have a better idea about, have a better chance at recruiting more follicles. Now, the second question, what was asked was, why did they use clomiphene and letrozole together? And I've often wondered how it would work. And I think Sachin may remember about 15 years ago, I was lecturing in Kolhapur and somebody got up on the audience and said, I get very good results combining clomiphene and letrozole. And all of us smiled. And I think quite often the doctor was probably right. I think together they work differently. And at least there are two papers which looked at ovulation induction by combination of both of these. The evidence is very small. And I think I presented a paper on a combination of this somewhere on fertility courses. So have a look at that. That was a very good paper which was published. So what did it demonstrate? It demonstrated that ongoing pregnancy rates were exceptionally good from the first recruitment and from the second recruitment. So again, this is a triangle I've devised, and I enjoy drawing this triangle. And what you want to find out, you've got a low AMH, and you can't change that. But what you can change is you can try and see if the woman has a variable follicle count or a fixed follicle count. And again, put your line at the 10 millimeter mark, because that's where recruitment and so starts. So rather, let's put it this way. What are the two phases of follicular growth? One is recruitment. Recruitment is independent of FSH. So it does not matter. So you giving any additional FSH does not change recruitment. What goes next? Dominance. Dominance is FSH dependent. And dominance depends on the constant FSH. So what's the difference there? So if you give everyone 450, does it mean all follicles will be recruited? No. So follicles which are larger get recruited first. Follicles which are smaller get recruited second. So can you increase widen the window? Yes, you can. And how can you widen it? You can widen it by decreasing the amount of FSH you can give. Because as soon as you give a high dose of FSH, you narrow that recruitment window to about 24 hours. And again, this was about 2 years ago. I presented this fantastic paper coming from Belgium, where they showed that the higher the amount of FSH you gave, you started narrowing the recruitment window. And often you saw a very few number of follicles being recruited. So what protocols to use? And heavy protocols often don't work. High dose protocols do not create more follicles. And you can stimulate what you can see. In very simple terms, you're not a magician, and you can't stimulate what you can't see. So that's in short about the case. And I think there's been one question, and the question was any pre-treatment in luteal phase stimulation. I think if you want to do, in fact, when you pre-treat, you're in fact doing a stimulation which is neither follicular nor luteal, because you've just controlled, it depends on when you're pre-treated. And in poor responders, again, there have been two papers which have suggested that if you pre-treat with the pill, with Proganova, with downregulation, you lower antral follicle count. So I don't tend to pre-treat in these cases. So